We are so grateful to Stacie Sinclair, who is CAPC's Associate Director for Policy and Care Transformation. I have known Stacie for a number of years, and of course, we, Kokua, are members of CAPC and really try to support their work to boost palliative care. So without further ado, Stacie, I'm going to turn it over to you.
Wonderful. Well, thank you all so much for having me here tonight. I'm really excited to talk about the new Serious Illness Scorecard and just grateful that you were willing to welcome me into your meeting to chat a little bit more about it. So, well, as Jeanette said, I'm Stacie Sinclair. I am with the Center to Advance Palliative Care. So I have been here since 2014. CAPC is a national healthcare nonprofit. So we are based in New York, but we operate nationwide, and we also have a few international members. So before we begin, I do want to flag that very exciting news that the Center to Advance Palliative Care, historically, we've had our national seminar. We paused that during the pandemic and in some of the years following, but we are back. And so we will be in Philadelphia from September 15th to 17th, and there's still early bird rates between now through April 30th. So just wanted to let you know about that before we dove in. So really getting into the heart of it, why a serious illness scorecard? And I think most of you in the room will know some of the next slides that we know that the experiences of people living with serious illness, that the number of people living with serious illness is getting higher and higher, not just adults, but also children, and really illness across the lifespan. And that the US healthcare system is not set up to meet their needs. So once you're diagnosed, patients and families often get poor and fragmented communication. Poor symptom management is one of the top drivers of emergency department utilization, because if folks are having a pain or symptom crisis, the system's not set up to meet their needs in the community or in real time. And so that drives unwanted and unnecessary utilization. And that the needs of patients can be so great, and it's up to the caregivers, often unpaid, to take on or be the backbone of the US healthcare system. So actually, in response to that question of what book am I reading, I'm reading Stand By Me, which you can't see, but this is a book by Alison Applebaum, Dr. Alison Applebaum, who's standing up a caregiver clinic. And so when we talk about caregivers, actually, this is I would highly recommend this because it's very, very practical and it's been helpful for me. But we know that unpaid caregivers provide something like $600 billion of labor unpaid to the US healthcare system. And so it's really a true burden on them. And so then what patients and families need is regular screening, management of symptoms, being able to proactively identify what the burdens are, and then come up with a plan to address those needs. Making sure that there's informed decision-making, that their clinicians know how to first ask them what quality of life means, and then be able to develop a care plan that is customized to what makes life worth living, and also to be able to navigate all of the ups and downs of serious illness. Obviously, support for the family caregivers and assistance with personal tasks. And then as the needs get greater, being able to have reliable access to specialty palliative care teams. CAPC has also recently increased the work that we're doing to better understand the experiences of underserved populations living with serious illness. And so a few years back, we started our project for understanding the experiences of Black patients living with serious illness. And then recently we've started a project on Hispanic and Latino patients living with serious illness. And I think we're going to be looking closely at different populations to better understand, but we want to take it sort of systematically, because we know that we don't want to lump everyone together, and really to be able to understand the individual nature. So I will say that in our research, we have seen that there are disparate experiences based on race and ethnicity. And so we saw that Black and Hispanic patients have a higher, or older adults have a higher proportion of not reporting not having had their care preferences considered. And then also much higher utilization in the emergency department in the last month of life, even 1 year post-diagnosis. And so seeing disparities like that and trying to better understand what is driving that and what can be done to improve that. So CAPC has historically offered something called the state-by-state report card. This was started in 2006, and we had 4 editions between 2006 and 2019. And this really started when there was not a lot of information about specialty palliative care at all. And so that first report card was really an effort to create a foundation for what does or where is palliative care across the country, and be able to create some sort of metric to be able to see where we were. And so in many ways, it was almost a marketing tool. We had one metric, and that was the number of hospitals with 50 or more beds reporting a specialty palliative care program. And we took that percentage and we converted it into a letter grade, and then we used that to compare states to each other. And then we had some front matter that would explain what is palliative care. And then on the back side, we'd have some general policy recommendations about what could be done to improve access. But really, those grades were just based on that one measure. And we'll say that it was a very successful tool because we saw significant growth in the field over that time in the number of programs that were available. We would bring these reports to our Hill days when we were meeting with state legislators or federal legislators to say, this is what palliative care is. You can look at it, you can see how your state fares and how you compare to others across the country. And so over that time, we saw the number of programs grow. We saw increasing understanding about what palliative care is, who it's appropriate for, and how it can improve the experience of illness. But by the time we had gotten to that 4th edition in 2019, we had started to see performance level off. And we've also seen that we started in the hospital setting. That's where we had the data. That's where palliative care started. But we also knew that palliative care has grown outside of the 4 hospital walls. And so as we were thinking about whether or not we wanted to do another iteration of the report card, we realized that the field has gotten more sophisticated. There's a lot more information about different aspects of palliative care. And so we thought it was time to maybe try and tell a new story. So enter the Serious Illness Scorecard. And the goal here again was to go into greater detail about what we knew about each state's capacity to deliver palliative care or to advance palliative care initiatives to better support people living with serious illness. And so we went from 1 measure to 10 measures across 5 domains. So this lays out the 5 different domains. The first one is the availability of specialty palliative care. So we did carry over that data from the American Hospital Association survey, which does look at the 50 or more bed or hospitals with 50 or more beds reporting palliative care programs. But then we also pulled in the count of each state's certified hospice and palliative care professionals, and then normalized that to per 100,000 people in the population. The second domain is payment for palliative care services. I know Hawaii is so well acquainted with this given your recent tremendous success, but because this is an area where we've seen more activity at the state level, we wanted to be able to start to track where is this happening? Is there legislation or regulation that expands specialty palliative care? And then we also wanted to look outside the public insurance to see if the largest commercial insurance provider in each state had a unique benefit or unique services for enrollees with serious illness. Beyond that, the third domain is that not a lot of this work gets done if there isn't a strong champion organization in the state. And so we also looked at the existence of an active state legislatively established state palliative care advisory council, and then also whether there was a regional, state, or local palliative care coalition. In the fourth domain, we know that there's never going to be enough specialty palliative care to meet the needs of everyone who's living with serious illness. And so then we also looked at relevant medical and or nursing continuing education requirements to see if there was something that was relevant that could be tied to building capacity in the skills required to do a good job caring for these patients. And then we also looked at the count of clinicians who completed at least one CAPC course per 10,000 clinicians in the state. And the reason that we used CAPC information is because that's what we had access to. And certainly we're always open to feedback about how to improve or look at different things. And then finally, again, we recognize that the needs of people living with serious illness goes beyond primary and specialty palliative care to really look at the systems and supports that care for these patients. So we brought in information. We looked at for children, for seriously ill children, whether or not they had there was a waiver in the state that went beyond the basic services that every state has. And then we also looked at AARP's long-term services and supports scorecard and brought that in. And so for each of these measures, we then collected the data, calculated it, each looks a little different, and then we combined that into a score where each state was then assigned a rating out of 5 stars. So without any further ado, how did Hawaii perform in 2024? The state got 3 stars, and I'll highlight that's actually quite a good score. We know, and as Jeanette said, we've been working together for many, many years now, so I feel like I've had, I wish a closer front seat window into what you're doing if I was a little closer, but I feel like I've been able to cheer from you from the mainland around all of the tremendous work that you're doing, all of the advocacy, all of the coordination. So we can dig a little deeper into this score. And I'll say too, most, if not all of the visuals that I'm sharing are available on the scorecard website. So you can certainly pull that up after. But this is our cheat sheet for the state performance by each domain. So within the specialty palliative care availability, one variable scored in the domain scored above the median. In payment for palliative care services, you got full marks there. For structured champions, advocacy, and support, we had one variable that scored in the above the median, and then building specialties, building skills outside of specialty palliative care, we didn't see any variables that scored above the median, and then for foundation for functional support was one variable. So looking a little more deeply in that first domain, specialty palliative care availability, like I said, we did carry over that metric of 50 or more beds, that self-reported palliative care program or unit. This is again to the American Hospital Association annual survey. And so this highlights pretty well why we no longer wanted this to be the single grade that determined a scorecard or a report card, because 81.8% is actually a pretty high percentage. But as you'll see later on, we have the ones that got full marks were in like 95% and above of hospitals that offered it. And so it is a fairly topped out metric. So it's important to keep in there, but also something that we just wanted to balance out with other pieces of information. Pulling the information from the American Boards of Medical Specialties and other boards, we found that there was 7.01 certified hospice and palliative care professionals per 100,000 of the population, which puts you in the top quartile, and so got full marks. Obviously, we know that you do have existing regulation, the approved CMS waiver for specialty palliative care for pediatrics and adults, and so that was full marks. And then also the largest, we found that Hawaii Medical Service Association Blue Cross Blue Shield was the largest payer, and that they offered a unique benefit for enrollees with serious illness. So that was full marks as well. When it came to the hospitals that we got from the AHA, This is the only information. I asked my research lead what we could share, and this was it. So these are the names of the hospitals in Hawaii that are in the AHA data. And so this is what they were able to report was whether or not they had a palliative care program. So you'll have access to this deck. I'm happy to give it to you, but again, this is not data that we collected, but this is data that we got from them. And I'm afraid we weren't able to share which ones were categorized as urban, rural, or suburban, but this is, at least you can see this list here. So then moving on to the third domain is structure champions advocacy and support. The existence of a legislatively established palliative care advisory council. I know we've had conversations about this, and I have to caveat this here. I see you smiling. So one thing, and I will reiterate this later in the presentation as well, but part of coming up with the methodology is that we know that a lot of states are doing a lot of different things to be able to advance palliative care in any way that they can. That may or may not mean that all 10 things that we were adjudicating are absolutely the thing that you must do. Hawaii has a very robust network of champions that is well coordinated and is doing the work. So later on, when we talk about what does this mean, how does Hawaii act on this, I would not necessarily say that pursuing a legislatively established advisory council is a meaningful recommendation for your state. If you had one, it would up the CAPC score, but in terms of the ability to get work done, that probably isn't the highest and best use of your time. So I really want to underscore that, because there are things where you could take actions to improve your score in the scorecard. And in some states, having that advisory council might actually be a real difference maker. And in other states, there might be other more meaningful actions that you can take. So I want to say that now. I'm sure I will say it again in the presentation, but I just really want to contextualize that for you. That said, you did get full marks on the existence of a state pediatric palliative care coalition, and we were able to see and incorporate Kokua into your report. So there's that. When it came to building skills outside of specialty palliative care, we did not find any relevant medical and/or nursing continuing education requirements. We were looking at whether or not palliative care was specifically mentioned, any topics on pain management, or dementia, Alzheimer's, or end of life, and we couldn't find those in medical nursing. And then we also pulled in, again, the count of clinicians who completed at least one CAPC course per 10,000 clinicians in the state. And so that metric was in the second quartile. Finally, when we looked at kidswaivers.org to see if there was an additional waiver above and beyond sort of the basic waivers that we saw in every state, we didn't see, I think it's the Katie Beckett waiver and the TEPRA. So we didn't see anything beyond that. And then, but on the positive side, in the AARP long-term services and supports scorecard, Hawaii was ranked 8th. And so that put you all at the top for community supports. So bringing all of that together, that gave Hawaii in total a 6 out of 10. Unadjusted, that's 3 out of 5. And then for some states we rounded, but for you that ended up rounding to A3. I can quickly go through the national performance, but I mean, you'll have these for your reference. This is what I was saying earlier. I mean, the top quartile, to perform in the top quartile for hospitals with 50 or more beds had to be above 94.3%, which is just a very high percentage rate. So these were the states that were at 100%, and then the lowest scoring state was Arkansas at 45.5%. When we looked at the certified palliative care professionals per 100,000, in that measure, we included MDs, APRNs, RNs, pediatric RNs, and social workers. And so pulling that in, the top quartile was 6.6, but as you'll recall, I think Hawaii was 7.1. So again, the number of professionals per 100,000 was actually the highest. One thing that was interesting that we observed is that the professional count didn't always correlate with the availability of inpatient palliative care. So I think we'll probably do more digging to try and better understand that relationship. But we saw that Maine was one of the highest scoring states on professional availability, but only 88% of their hospitals reported having a program. So it may also be about the concentration of providers. When it came to payment for palliative care, primary specialty, we looked at Legiscan and CMS state websites to be able to identify where there was either legislation or regulation. We found that 13 states have something on the books. Really, it's Hawaii and California are the furthest along in terms of California's directive to Medicaid or Medi-Cal managed care plans, and then Hawaii's approved SPA. But then we also have states like Maine, Maryland, New Jersey and Washington that have legislation that says you need to assemble a work group to come up with what a palliative care program would look like. And then we did find some interesting examples. For instance, Illinois requires all of its commercial insurers to cover pediatric palliative care. So that was incorporated into this measure. And then for the commercial program, we looked at Becker's June 2023 listing of the largest commercial health plans in each state. And then went on each of those websites to see whether or not they had a unique service for enrollees with serious illness. And so we found 23 states whose largest insurers had such programs. Looking at the structures for palliative care champions, this map shows in green which states have an adult and or pediatric coalition. And again, those are looking at the public private partnerships, usually multi-partners that are coming together to advance some sort of priority around improving care for people living with serious illness. And then the orange is the legislatively established advisory councils. And then in green, in the light blue is where both exist. This is then the map of that we could find of relevant topic-specific requirements in medicine and or nursing. And I mentioned what those looked like. So there was actually only 3 states that mention palliative care specifically, and that's Vermont, New York, and Rhode Island. And then other states have a combination of some of these other topics. And then the prevalence of clinicians who completed at least one CAPC course per 100,000 or 10,000 clinicians in the state. The highest was Michigan with a very large percentage large number of courses, and then Wyoming was the lowest. And I think the reason that we put in this measure is because it was the one that we had information about in terms of what do we know about capacity building in core palliative care skills. And that there's an opportunity because we do find that a lot of institutions that have CAPC membership, the vast majority of people in that institution don't actually know about it. And so for states that are looking to do an education initiative, part of that is just saying, hey, a lot of folks have CAPC and don't even know about it. So if you can find those organizations, and in the individual state report, we actually give that information to say X number of institutions in your state already have CAPC membership, and then say, if you have that, then you can take advantage of it and you can use it. And that's intended to drive utilization for that as a way to get started with low-hanging fruit. Finally, the Foundation for Functional and Caregiver Support, we did find that 32 states had Medicaid waivers for children with serious illness that went beyond basic home-based care. So for instance, respite care and sibling counseling in Illinois, and then the AARP LTSS scorecard, which showed again how supportive the infrastructure outside of specialty palliative care is for people living with serious illness. So that's the national picture in a nutshell. So when you look at the scores overall, there was a fairly normal distribution in the ratings. So with 3 stars, that really puts Hawaii in the middle. But I think something that I want to say there is that I was telling Jeanette earlier before the call, this more than anything is intended to be a tool to support your advocacy. And so for states that are performing really well, I think something that you'll notice about the scorecard is that it still doesn't speak to what is necessarily the quality of the care. It doesn't speak to the penetration. It doesn't speak to the interdisciplinary nature or any of those quality measures that we really see that are having that direct impact and outcome. And I think that's also why we wanted to pull in the ACT index in the individual state report to be able to round that out. And so even for the states that got 4.5 stars that are saying, well, CAPC just says that we're the best. No, this is meant to say you have done a ton of work to build the infrastructure, to advance palliative care initiatives, and there is still plenty of work to do to be able to improve quality of life for people living with serious illness. On the flip side, as you can see, the way that we developed or selected these measures, they're not that easy. Like each measure takes a ton of work, a ton of coordination and prioritization and resources to be able to achieve them. And so no states scored 0 stars. Every state has done something. And so even if it's a low score, that's also something to be celebrated. And so I think that you can see that reflected in what Hawaii did too, that there is so much to celebrate. There's so much work that you've done, and there's so much work left to do. And so however we can frame the story, that when you're talking to your policymakers, you're talking to your advocates, your champions, this is really intended to support that in whatever way we can. So pulling in, we did break down what was the average rating by census region. So Hawaii is in the Pacific census region. So the average there was 4 stars. So then now what? As I mentioned, the scorecard is that one piece. It's that national roll-up. But then we also updated our individual state reports. And this was our effort to just catalog everything that we could find in each state about what we knew for palliative care. I will say that we are a team of 3 and that we had 50 states and DC to look at. And we're actually trying to build one now, build a report for Puerto Rico. So we are not going to know as much about what's happening in your state as you are, but this was our very best effort across 50 states and DC to be able to try and save folks from Googling and to just give you anything that we could find, anything that we knew. So the link is there to your report, and it has information on everything that we talked about in this talk, some tables and maps and charts to see how you compare the number of certified prescribers, the number of community-based programs that have reported and get palliative care, and so on. I pull in these. So these are the high-level recommendations. Again, this is not me telling you this is what that Hawaii should do, just that based on where the gaps are, or based on what the score is, these might be areas for exploration. But it really then is up to you all to decide what makes the most sense given your champions, your resources, your capacity. So a promising practice that we've seen or in other fields, actually not so much in palliative care, is that when it comes to the workforce, being able to defray the costs or loan forgiveness programs for folks who are specializing in palliative care, who are going to serve in underserved areas. We've seen that strategy play out in oral health, behavioral health, primary care. And so there's one state that we know of, Illinois, that has been trying to pass legislation that creates a specific loan forgiveness program for those who are going into hospice and palliative care. So that might be something to look into. Incorporating palliative care skills into continuing education requirements. Again, I'm flagging that because that's something that other states have adopted. that might be tough because I actually didn't see any topic-specific requirements for professionals in the state. So if there isn't that precedent, then it might be hard to get that in initially. But again, just something to explore for that primary capacity building. And then another thing that I'd seen in one state, and I'll go into this a little bit, but Kansas actually incorporated in 3 separate annual surveys for BRFIS, they incorporated a palliative care module. So I was able to find 2 from this first one was from it was actually 2021, but then they were reviewing the data in 2022. So in the 2021 BRFIS, they had 3 items on palliative care. And so the first one was related to an advanced directive. The second one was on what we would understand to be palliative care, asking folks if they've ever received it. And then, did you find this useful in helping manage your pain or symptoms? So this was 3 items in 2021. In 2016, they actually did a 9-item module in the BRFIS, and I can send you the full PDF. I just didn't want to bore you on the slides. But when I saw that, I was kind of blown away by the level of detail that was included in the survey, because this is something that already goes out to beneficiaries or to people in the state. And so it's an opportunity to collect some really good data on, do you know if you have these, or if you've received this kind of care? Do you know what palliative care is? Have you gotten it? Have you seen a difference in your symptoms? And I have the PDF somewhere too. So I can, again, I'll share that with you, or certainly if we want to dig into it later in the presentation, we can. Something I wanted to mention, I know you've heard from CAPC and from Kokua about participation in the getpalliativecare.org provider directory. We did not include community-based palliative care in the actual scorecard algorithm. And the reason that we didn't do that is because we don't have a good denominator. And also because at this point, participation in Get Palliative Care, we think, is still quite really underrepresents the amount of palliative care that's out there. And so we didn't want to turn that into a measure that was really holding states accountable or comparing to each other when we weren't sure about the quality of the data. But that does mean that there's an important gap that's missing in our scorecard. So we didn't have it there, but we do want to continue to see participation in this. I think first and foremost, because this is where patients and families go to find palliative care. But then as a secondary benefit, we can then also use that to better understand the landscape for ourselves. So we included the information or the counts of what we knew of programs that had self-reported having palliative care in the provider directory. So if you go on getpalliativecare.org and you don't see your program listed there, or you don't see your friend's program listed there, please encourage them to fill it out. We're asking every state across the country to do the same. Some of the things, just looking at then now the 50,000-foot level, about the states that had done or seemed to have a greater capacity. Lessons learned were that we really saw meaningful coordination across interested parties. And so, again, I'd hold Hawaii up as an example in terms of the work that Kokua has done, the integration with your legislature, with MedQuest, with Hala, really bringing together the payers in your state, bringing together all of the interested parties to be able to advance what the initiative should be. Also focusing, we really wouldn't want on that list of policy recommendations, you don't want to attack every single one or do every single one. There's not enough resources, there's not enough attention. And so to look at that list and say, based on where we are today, what are the 1 or 2 things that we really want to elevate and put all of our attention towards? Understanding current resources in the state. So we've seen some states that are collecting information on palliative care and programs and specialists via survey. CAPC was really pleased to work with the Coalition to Transform Advanced Care to come up with a sample template survey that states could use or adapt to better understand the landscape of where palliative care exists and what it looks like in their states. And then CAPC and the National Academy for State Health Policy. I need to underscore that NASHB is incredible. They have been doing work for the last 7 or 8 years at this point to be able to develop resources that speak specifically in the language of state officials and those who are some of the decision makers on investing in palliative care. And so being able to look at what are the resources that exist on CAPC and NASHB and then leverage those rather than reinventing work for yourself and then planning for implementation. So it's not just getting the legislation across the finish line or standing up the program, but then who is going to be actually delivering the care? Where is the accountability? What are the resources to support that work and being able to look at those things in parallel? So I have one thing just to say too, that if you're interested in sharing that, we do have a social media kit with a lot of resources on how to promote the scorecard and the individual state reports. We have newsletter articles, we have social media, sample language, and then we also have individual state graphics if you wanted to go into the folder and plug that into any of your newsletters or things. And then I did talk about the national landscape, but we did a briefing in December where we go deeper into the national landscape. So I think that is it, and I will open it up to questions or discussion.
Great. Well, thank you so much. I think, I was going to say we can check some of the questions in the chat because people are interested. I wanted to clarify when you were talking about education, because people also were saying, hey, we do so much education. This is on a state level that there's not any requirements for doctors, nurses, social workers around licensure and palliative care. Is that right?
That's right. That's right. Just specifically that. Yes.
Yeah. I'm trying to rack my brain about this, but I recall that 100 years ago, somebody said that never happens in Hawaii because our healthcare association covers everybody, the hospitals, the hospices, the long-term care, everybody, and nobody likes additional requirements. It could be wrong, but that's something that I have somewhere in the back of my mind that it's like, oh, don't even bother because no one ever wants requirements. But maybe somebody can prove me wrong, and that could be something to look at. So
no, and that's that's a really good point. And if that's the reality on the ground, I think this is where sort of where I have to hand it off to say, I don't know about the landscape in your state specifically. You are going to know way more than I do. And that's true. I think what we've seen across all 50 states is that there are some states that do go deep into topic specific requirements for renewal of your doctor or nursing license. We also saw that sometimes there are waves. And so historically, you've seen a wave of topic-specific requirements in response to a public health issue emergency epidemic. So the most recent one was that we saw a ton of specific requirements around opioid education and prescribing and substance use disorder in response to the opioid epidemic. And so that has been a wave where we see a lot of those requirements that are still in place today. Prior to that, in the 90s, we actually saw that there were a lot of topic-specific requirements related to HIV and AIDS education, because that was one of the largest presenting health issues at the time. And then over time, as that public health emergency lessened, then states were either removing them or they were expiring. And so, again, every state is going to be a little bit different about the legislature, the policymakers' appetite for telling clinicians what to do in their professional development. And so it comes then down to the relationships and the feasibility. and also what you think the impact is going to be. There are some states where they're never, I don't want to say that actually, I take that back. Payment is infeasible for the time being.
Mm.
And so if there is anything that they want to advance, probably the best option is to look more at education or public awareness, because that's just going to be the only lane that's available. And by advocating for something like that, even if you don't get that over the finish line, there's still going to be the work of having a policy priority to mobilize around, making meetings with your policymakers to give that ask, educating folks on what is palliative care. And so in some ways, I even say this with PACHITA, the Palliative Care and Hospice Education and Training Act, that really does need to get passed. I'm not saying that it doesn't, but there have been a lot of successes just by having that as a vehicle for the field to mobilize around.
Yeah. Great. Well, I'm wondering if anybody has any questions. I had a couple of things that came up, but wondering if any of our fabulous participants have anything that came up. Daniel Fishberg.
Well, I had questions, but then you said fabulous, so I was going to wait for those people to talk. And
Yeah, well, you know.
Hi,
then you moved
Daniel.
on to the mediocre people. Like, well, Stacie, thank you very much. That was really interesting, and I appreciate you taking the time to go through it with us. My first question is actually for the group, because I always I look at the report card, or I've looked at the report card over the years, and I recognize, especially for the programs, it's all kind of self-report, right? So I'm just curious, does anybody know what the program at Kula or Kuakini look like?
Yeah, I gotta say, Stacie, there's a bit of humor about some of those that we so
It's I think this is more accurate. I mean, I've seen other ones
yeah.
for inaccuracies, but and I'm sure every state is like that. But so it wasn't joking. Does anybody know? Is there anything going on at either of those? Because our residents rotate also at Kuakini, and all they just keep asking us is like, "Do you do consults over there at Kuakini?" Because the next
Well,
question,
Daniel, people tell me that Queens has a palliative care program over at Kuakini. So if you don't know about it, then I would say, because they were talking about a consult service at Kuakini. So,
interesting.
and the other one too that's missing is Maui Memorial. So Maui Memorial has a robust inpatient palliative care program. They do a
Yeah,
lot.
yeah,
So Kula, I don't know about, but Maui was not on that list that you showed us, Stacie. Because,
okay.
in a small state, we know everybody.
Right, you
So
know,
that for us
everyone.
is what makes it
Yeah,
interesting.
and I'm sure
Yeah.
that's true across all.
Are you talking about this one, this slide?
Yes.
Yeah.
Oh, yeah. And so there, this is where I am woefully inadequate, because this is, I think it's the AHA annual survey. So
Mm.
they administer it.
Yeah.
I think they reach out to every hospital. I think it is ultimately still attestation. And so I'm sure they do some work to try and verify, but I don't know that it's as in
Yeah.
depth as what anyone in their state could do. So this is the best data set that we have
Yeah.
access to.
Yeah, and it really was not a gotcha
Oh,
question.
no.
I wanted to ask anybody else if they know about something that I don't. I changing topics. I appreciated what you said about legislative councils and the value, because that's something we've sort of kicked around here, and I know it's state by state, but in terms of getting something done, uh, the state legislature is not always the top of our list of how to do things. And I respect that's, kind of what you were messaging. Are there states where that's really been a very effective way
Yeah.
to palliative care? And could you give us examples of that?
Absolutely. Yeah, these advisory councils are hit or miss. I say that as somebody who was the chair of Nebraska's Palliative Care Advisory Council while I was living there. And I'm really proud of the work that we were able to accomplish, but we had no resources. We had minimal support from the state. And then finally, as I was leaving, we had a governor that refused to make appointments. And so I think it was through sheer grit and the fact that with CAPC was just trying to take everything I could from my day job to be able to infuse it into that council that we were able to get anything done. We were able to put out position statements on opioid prescribing. We were able to come up with a report with recommendations and canvass a state. We were able to get a state a legislative definition of palliative care outside of hospice passed. And then we were able to come up with a strategic plan partnering with University of Nebraska Omaha, their strategic planning class. And then we were starved and basically couldn't work because now we have 3 people out of 9. So we were able to get some stuff done, but I think at that point, like, I don't know how much more we can do in that capacity. The other 2 examples that I have where I've seen, actually 3, where I've seen things work really well are Texas, where people who were at the State Department of Health who were running the council or providing staff support to the council were some of those who were embedded in their Medicaid value-based payment initiatives. And so it was having the right staff at the table and very professional people who maybe were in Medicaid value-based payment and learning about palliative care for the first time and saying, oh, wow, I didn't know anything about this. And so that Texas Council has been able to, again, get continuing education initiatives off the ground, pass a legislative definition of palliative care, passed a way of basically programs registering themselves as a separate, not a separate palliative care licensure, but within their home health and or hospice facility licensure, they can indicate that they're palliative care. So that's a way of tracking also where palliative care is being delivered. And then they're also looking at the value at payment in that way. Similarly, in Alabama, when I went to talk to their council, at the table, I was really amazed at where folks in the state government or where they were sitting, they were also at the table. And so I think this was like in 2018, where they were talking about some barriers in prescribing, the council members. And one of the people at the table was somebody who was responsible for the state PDMP and was hearing that there was something in that was a barrier to the physicians who were trying to prescribe opioids. And so we're able to take the information that they heard at the table to make a change to the PDMP in real time to be able to reduce a barrier. So those are the ways in which, if your council has resources, if you have the right people at the table, if you have a legislature and an executive that understands the value that it can deliver, then these councils can be very effective because there is that endorsed mechanism that's embedded into the state and has that state support. If you don't have the resources, or in our case, and again, I have so much love for Nebraska, and I think that we really did accomplish a lot, but we were embedded in the Women's Health Initiative because that's the place where councils that don't have a home that's where they get turfed. And so we had very supportive people at the state who had very little subject matter expertise on what we were doing and didn't have access to the things that might have been directly related to it. So it is hit or miss, but when it works well, it can work really well. Sorry for that monologue. I'm very passionate about it.
That's helpful because, in some ways, what I'm hearing, it sounds a little bit analogous to between whether it's Kokua Mau or newer Huipuahala here, not being state, we sort of have the flexibility to focus on the things we want to focus on, and then reach out to, the legislature as needed. But I was just interested to hear if it's within, the legislature, if that is an overall advantage. It was related to another question I sort of had. I totally agree with what you were talking about, is how coordination, across silos is such a key to success, sort of analogous to that point. And I sort of impressed moving to Hawaii that things seemed so much easier here to do that kind of coordination because of the size of being smaller than, say, New York. Um, Looking nationally as you've had, have you found that pattern that smaller states tend to do a little better with that? I mean, when looking at the color code, some pretty big states there, look pretty effective. Um,
Yeah, I think it depends. I don't know that we could say that there's like a trend where where we do see a clear trend is that smaller states perform much better on that the hospitals with 50 or more beds usually. Like Delaware and Rhode Island, I think they end up having like
or
100%, but it's
Yeah.
one for
not that
one,
hard.
right? Yeah.
Right. Um, well, I think less so in terms of the coordination. I think again, it just really depends on how much of a priority it is. So South Dakota actually has done quite well on the coordination because they had some strong health systems that put in a HRSA grant a few years back. So they got, I think, $100,000 planning grant and then a $900,000 grant over 3 years to stand up a palliative care network in the state. And so they were given funds to go out and knock on every single door and find just about any program that they could to build that list, to make the connections, to offer monthly education, to do surveys. And so we wrote a paper on it. I think it's I can certainly send it to you all. Now, the status of HRSA funding more recently, it might not be a vehicle that's available in the same way currently. I would hope that that changes in the future, but it is something to look into. So again, yes, the size of the state. I mean, the fact that also you all have been working on this for decades, right? Yes, Hawaii is small. Yes, it is relational. And you have been working on this for years and years and years and years and years. Same with California, that it's actually, there's a lot of coordination there. See, the California Healthcare Foundation has poured itself into building that infrastructure. So it really just depends on the attention, the prioritization, and then the resources.
I don't want to dominate all the questions.
Keep going,
But
Daniel.
I guess I had one other one. I was interested, the distribution of uptake of CAPC courses.
Mhm.
And did you have any thoughts on what are predictors of that? Is it something as basic like there's a large health system that mandates the education and prioritizes it, or?
Yeah, I can't. That's a really great question. I can't necessarily speak to exactly what it is. I think if you have a strong champion who's well positioned within the organization that has membership, has relationships, and getting the word out, that's a big one. Yeah, that there are some systems that made it a requirement. They set up a learning pathway and they said, you need to complete these 5 courses. We can track everyone who has created an account and done what they're supposed to do, and that can drive participation. And then the other thing that we found just looking at our own data is that once people take that first course, once they sort of break the seal to set up the user profile and take the first course, then they take on average about 6. So it's really the barrier is sort of getting through the threshold of taking that first course, because once folks do that, then they tend to come back. But that depends on being able to take the time out, being able to figure out the technology, knowing that you even have it, which is a huge barrier sometimes.
Right.
So.
Thank you.
Yeah, thank you. And for me as a policy person and as a public health person, my approach to these things with Kokua Mau um, is often to look at policy and what changes and how to do that. And you are, as Daniel said, for us, looking to our legislature to do this is not my top priority. We are happy a couple years ago, the fabulous Lauren Kim from the Department of Health created advisory committee, which sparked, a variety of things. And it is one of the reasons we now have this Medicaid benefit is we have the definition in statute, and we have a longstanding 25-year coalition. We also have the buy-in from our Medicaid office. Department of Health is super supportive. So there's various factors that come into play. And the question is how, what it is what we could be working on. There's a couple things, Stephanie, for the next version that have happened since that came out. So I'm hoping our little stars will increase. So the Medicaid's community palliative care benefit was approved since this came out, which is interesting. I was trying to figure this part out, that it covers both adults and peds, but it also covers Medi patients. So I think that'll be really interesting to see what that impact is, because there are, that definitely in our state, unfortunately, it's over a third of the state gets Medicaid. So it's a big deal. So that's really important. I'm glad to know that my failed efforts to get people to sign up for the directory didn't influence it, because I continue to try to get people to sign up. So, but I will continue to do that. When I look at this, I'm quite interested in this concept of licensure and education, and wondering, are there other small states, because maybe that is a factor, who have been able to do the licensure. I liked how you phrase it. Providers don't want to be told what to do. So I thought that was interesting. And so I don't know, do you know any states that, and you can also get back to us, but.
Yeah, no, as I'm like I said, I think some states are a lot more prescriptive around continuing education requirements, whereas others are completely hands off. I think there's one state that doesn't even require continuing education requirements for
That's
for
exciting.
doctors at all, which yeah, exciting is a word for it. So I think it does come down a lot to each state and the culture there. So like I said, the 3 states that I know of that have put in palliative care, Rhode Island is clearly quite small. Vermont is small. New York is not small at all. Unfortunately, a limitation of the data that we have is that we can't necessarily speak to what has a huge impact. So a lot of this report card is just the building blocks, like where have states invested their attention, and what could that mean for their ability to advance initiatives. But we haven't been able to do a pre-post of New York State's Palliative Care Information Act or Palliative Care Access Act to see, like, prior to requiring that every emergency patient with serious illness be given a pamphlet about palliative care, we couldn't see a before and after about what necessarily the impact is. But like I said, there's enough anecdotally to say that the work of trying to advance that initiative and building relationships and having people come together to mobilize around it, also there's the direct benefit, but then there's also the indirect benefit. And so while we can't quantify it, we can highlight that as something that has to have an impact in moving the field forward.
Yeah, and one of the things I think we're all interested in is as we build the new Medicaid benefit. Like, it hasn't gone live yet. We're now in the process of building that. What are the positive things that are going to come out of it? People have to be educated. You have to build the skill set. Other players are going to get involved who are not currently offering palliative care. Long-term care facilities, for instance. I know there's a number of them that are thinking about it. So this is really, it's good to be thinking about that. And then, which leads into my other question is, for us, you had mentioned, I think that some states mandated some kind of palliative care, so not Medicaid, but other health plans
Right.
offer that? Who is that? And how did
Right.
that
So,
work?
so it was Illinois that
Mm,
required that commercial plans cover pediatric palliative care. And
mm.
so I remember seeing that. I don't have the full story at my fingertips right now, but I can go into that and send you the information where that was required.
Yeah. Okay. Great. And I don't know if folks remember the presentation we had from Tori Fields last year on the ACT index. That for me was a huge eye opener because we had this huge crash in number of home health um, providers. So I was expecting that also to be factoring into this because that then for us, what we saw was this dramatic decrease in number of home health people because of the pandemic. And then that, of course, can lead to other things like the hospitalizations and things like that. So one of our issues in Hawaii continues to be staffing, professionals. It's expensive here, but everybody and everyone has a crisis. So that was something I was kind of expecting. I remember my other question. You had mentioned, and I noticed that we had this very large number of prescribers, like way above the national average. Can you, like, how do we utilize that to
How
like,
do you
what does
utilize
that
that?
mean? Thank
Yeah.
you.
Yeah. Oh God, that's tricky because that's one that it's a little hard to spin about like what happens and why or why do these numbers exist. I can
Mm,
tell you that the where we collected this information was that we went to again the American Board of Medical Specialties annual board certification report. And so I think there are 10 specialties that offer hospice and palliative medicine as a subspecialty, and they break it down by state. So we pulled all of those counts for MDs. Similarly, we went to the hospital and hospice and palliative care credentialing center for nurses, and we pulled the numbers for APRNs, RNs, and pediatric RNs. We went to the social work certification. We talked to the chaplain, the two orgs that certify chaplains, and pulled in all of those numbers, and then aggregated that, and then converted it to per 100,000 of the population. What we don't know from those numbers is who is currently practicing, where they're
mm,
practicing, what they're like, or if they're still doing, if they're doing palliative care, they're just holding the certification in palliative care. Are they retired? Are they active? We don't know any of that information. And so, or in for a lot of states, we don't even know, like if you're sitting on the border of a state, are you practicing in one state or are you practicing in the state that's actually like the hospital that's closest to you, but that's over state borders? And so that is where there is some fuzziness in the data. So I was surprised. I mean, that 7 is high. Um, and I don't know if your experience has necessarily borne that out. I imagine that you don't feel like you're swimming in a glut of palliative care providers. But yeah, I
Actually,
recognize it's a question mark. So
I wasn't surprised. Jeanette,
okay.
you may recall that MSHA, many, many years ago, did her own report on this. I think it might have been we were,
mm.
before it was an ABMS specialty. And I think she was able to go to the American Board of Hospice and Palliative Medicine website and just search by state. And
Yeah.
uh, diplomat per capita, Hawaii was really, really far ahead. Um,
I
And
think,
I
can I
can,
ask a quick question? So I think maybe part of the disconnect, this report is heavily hospital based, right? So my question is, if Kona and Maui and some of the other off-island hospitals, off-island, smaller, more remote hospitals, if they would have participated in this survey, would that have impacted our score? Would it have taken us from a 3 to a 4 had they been able to show that they're doing palliative care? Because we do have a large number of hospice and palliative care certified providers and very robust programs as a
yeah.
whole for the state.
I think participation on the AHA survey, if that percentage had been higher and that had been in the third or top quartile, that I think would have bumped the score
Yeah.
up. That's the one piece where I could see that impacting the score.
And then, so Stacie, to understand Trisha's question, we have a lot of community-based palliative
yeah.
care. Does that, like,
No, the community-based was not factored into the algorithm, in part because we just don't have enough information.
got it. So maybe if people participate in the directory in the next, when are you going to do this again? 2 years, 4 years?
Yeah, roughly 2 years. Don't hold me to this, although I'm speaking onto a recording. So May of 2027 is when we anticipate the next one. Again, I'm saying that lightly. We will see, but that's our plan. Is that we tried to develop it in such a way that it'll make periodic updates actually a lot easier. Whereas with the report card too, we were doing that from scratch every time. So we want to be able to update this regularly and then be able to start to track trends based on this.
Good. And I just wanted to finish up what Daniel was saying. Daniel, do I remember that there was something like people retire here? So they were like listed in they weren't really working, but they were here, or they just did part-time things, or is that my faulty memory?
That's not what I'm recalling. I think, when because I was able to search that too, and those people were legitimately here and practicing. There were a couple people, like there's somebody who actually trained in the program like 1 year after me back in New York, and she does primary care, not palliative care, but she is board certified. But it looked pretty legit. Again, this was a long time ago, and I think it was the American Board of Hospice and Palliative Medicine. But I believe that data, Stacie, that I mean, because we have some corroboration for it that I think a lot of our we have a lot of geriatricians here because we have one of the largest geriatric fellowship programs in the country, and a lot of those folks grandfathered in early on. So I think that was one reason we kind of had an edge.
Yeah, that makes sense. I shared in the chat the ACT index in case people forgot that. You can download this and see, I am continued to be shocked about the huge drop off in home health that happened, and with the ACT index. So because before we were usually up at the top and doing well, which is where we want to be, Stacie. So for us to not have at least 4 stars is a bit traumatic. So we do want to be doing better. So I really, we're working on that. So I'm if there's no more questions, I'm wondering if there's any more questions. We can let Stacie. Thank you so much for making time and answering our questions. I think there's some good food for thought, and also thinking on our side how we can really make a difference, and what those pieces are to improve things. So I appreciate you running through with it. And then, of course, for people on the call, if you have other ideas, I can certainly look up our BRFSS question from before, because the Department of Health has been super supportive throughout this. They were actually part of the first cohort with NASHB Medicaid, and then Department of Health went. So that was they've always been supportive. So something to do now, resuscitate some of these relationships, and which we still have. It's just a matter of building those.
Yeah. Well, thank you so much for having me. You have my information. I will send you the deck. I'll send you the breakfast questions, and then any other information you need, you certainly know how to get in touch with me. So I just appreciate being able to talk with you all, and thank you for your work.
And thank you very much, Stacie. Thank you.
Have a great day. Good night.